السلام عليكم ورحمة الله وبركاته. Hello everyone and welcome to our webinar. My name is Noor Al-Madaj and I am an occupational therapist from Kuwait. I'm specialized in neonate and early intervention and I'm the founder of this group. I would like to introduce my friend Aisha Abdul Latif. She's an occupational therapist from Jordan. She's my second hand and without her nothing will happen. What happened? Today, our webinar titled with Occupational Therapy for Children with Cerebral Palsy, Home-Based Intervention, presented by Dr. Nisrin Alqatarneh. Am I right?
أيوة صحيح.
ممتاز. Dr. Nisrin is assistant professor in Jordan, in OT in Jordan. Hello and welcome, Doctor.
يا هلا فيكي زميلتنا نورا. Welcome everyone. أنا I am assuming إنه إحنا بنقدر نحكي عربي صح؟ ولا بتفضلوا إنه يكون إنجليزي؟
I prefer in English, but we can explain in Arabic if
تمام
you wish.
خلاص
Yeah,
إن شاء الله.
inshallah.
يعني welcome to this small and short and condensed workshop, I would say. I would like to first thank Noura and Aisha and everyone who participated in organizing this event and several others I've seen before, and I'm hoping we will have much more later to come. I would like to start by saying that I am wholeheartedly in support of our colleagues in Gaza and West Bank, who are now trying their best to put in efforts to help their patients. And this presentation, this workshop, and I know all my colleagues are trying their best to help out as much as we can. So I'm trying in this small workshop to give sort of an introduction, as well as focusing on home-based interventions for children with cerebral palsy, so that people in Palestine can be helped a little bit, at least, let's say, occupational therapists, physiotherapists, whoever wants to use this material can be helped to support children with cerebral palsy and their families. So I am aware that our audience consists of occupational therapists from several areas around the world. I will be directing my talk towards helping people under distress and war, and even people who are struggling to reach therapists and have health facilities available. I'm also providing a little bit of an introduction to cerebral palsy at the beginning. So excuse me if it's something that you already know, but I need to build that base before we can move on towards the components of home-based intervention. Okay. So I will not be able to follow the chat. So I hope if anyone is asking any question, maybe Noura, you can interrupt me if they want to ask a question, because I usually like to answer questions as they come.
Yes, for sure, inshallah.
Inshallah. So I put the first slide only in Arabic. So it says what we're going to do in this workshop. We're going to introduce cerebral palsy and how it impacts the child development, because this is the main aim of what we're working on today. We're going to look at the different types of cerebral palsy, how to practically distinguish between them. So this is directed towards therapists who would see the child without any medical information, how to just look at the features that they see in front of them and try to distinguish the different types of cerebral palsy. I'm going to run a little bit across assessment, but I'll focus only on observation. So that's the main focus, how to observe different skills and how to build our intervention on those observations. And the second half of this workshop would be the type of skills that every parent with a child with cerebral palsy needs to learn. So basically what a therapist needs to teach the parents so that their daily life can be easier, the feeding, the dressing, even the toileting can become a little bit easier by handling the child in a specific way, or carrying a child from place to another. I tried my best to collect information that does not include materials and does not include assistive aids, because I thought we need to focus on working without resources. So hopefully what we will discuss today will be helpful to anyone in the field. Of course, there are big sections related to using wheelchairs and seating equipment. And I'm happy to provide anyone who wants to learn about these things some resources to read about them. But today we're not going to talk about the use of wheelchairs or seating products, because I'm assuming people don't have access to those things. Okay, Bismillah. So the first thing we're going to look at is just the theoretical understanding of how a cerebral palsy child would have an impact on their development, mainly their motor development, but of course it will automatically have an impact on their sensory development, their cognitive, their language, and of course their emotional development. What we will do is we will look at the normal development in terms of the movement patterns, the postural control, the normal muscle tone, and how those different developmental components will lead a child with no problems, the normally developed child, to be able to move across the different milestones and develop from a baby who is lying on their back to a child who can walk and run and jump. And then we're going to compare that to what happens to a child who has cerebral palsy, and how the neurological impact on their brain would interfere with postural control, with their ability to move smoothly, with the muscle tone, and how this will impact the development of their milestone. What we need to start to understand is that both normal children, and I wouldn't say normal, so typically developing children and cerebral palsy children, they would move across the same milestones of motor control. Okay, so they will go through the different types of motor control, moving from supine to prone, sitting up, sitting sideways, crawling, standing up if they can achieve that, and walking. But the way that a child with cerebral palsy achieves this movement patterns and these milestones is impacted by the type of motor dysfunction that they have. And it would make those milestones look different. It would make those milestones less functional. And eventually it would impact their ability to contribute and to interact with their environment. This on itself would have an impact on their sensory development, their language development, their cognitive development, perceptual development, and even their emotional development. Because we know that children develop in all areas simultaneously. So it's all based on each other. It's an interdependence relationship between the different areas of development. So if a child has a motor delay, it will impact the different areas of development. And that's what happens with a child with cerebral palsy, because the definition of cerebral palsy is that it has a motor impact on the child's abilities. Okay, so everything else, the sensory, the cognitive, the perceptual, the emotional impacts are secondary to the impact that the child have on their motor cortex. The typically developing child will have normal muscle tone, so their muscles will be able to flex and extend smoothly. The tone would be within normal ranges, so the child would be able to use their muscles voluntarily and smoothly with no resistance. This will also have an impact on the child's ability to contract and relax their muscles and to do or compose coordinated movement, which is the essential aspect of conscious movement and motor control and praxis, which a typically developing child will have it achieved easily. Another aspect of the motor development is the normal postural reactions. So all the different reactions that the body normally develops, three main components. We have the righting reaction, the equilibrium reaction, and the protective reaction. Three components that will give the child the ability to have different postures. So while sitting, I'm able to raise my back up so that I can see in front of me, and I have a free hands so that I can use them. Or while I'm standing up, I can look and survey the whole environment around me with a full visual field, because my head is upright, my neck is upright, my back is upright. Then the gravity does not impact me because I have normal postural control. If my body shifts somewhere for some reason, so someone pushes me sideways, or I lose my balance, the other components of postural control will kick in. So I will have the righting reaction, which will have which will include, for example, if I fall forward, I will try to raise my back backwards, so to compensate for the loss of my posture. If I'm pushed sideways, I'll try to push my trunk to the other side, or even try to do a step so that I can open up my center of gravity or my base of control. My base of control would be bigger, so that I regain my center of gravity as balanced. If the shifting of my body is extreme, then I will use my protective reaction. So I put my hands up in front of me so that my hands will prevent my fall or decrease the impact of my fall. I will even cover my head to protect myself if I'm falling from a higher place. All of these are different protective reactions. The three of them are part of my normal postural reactions. The three components of normal muscle tone, coordinated movement, and contractions and co-contractions, which I will mention later, and the normal postural reaction will lead the child with a typically developing motorly child to move across the different milestones smoothly. So first, by moving from lying on your stomach to quadruped, which is like moving on your two arms and 2 feet, standing up, walking, running very smoothly, because the components are okay. With a child with cerebral palsy, what happens is that first the brain would have the neurological components of the brain, so the structure of the brain will have suffered some sort of injury. Now, it might happen while the child is in the uterus, it might happen during birth, or it might happen later. So something like a traumatic brain injury that impacts the structure of the brain. What happens is, for lack of oxygen going into certain areas of the brain, and it's different according to the type of cerebral palsy. When this oxygen supply is cut off for a period of time, more than 2 minutes, that's an approximate length, then this area, the structure of the brain, would lose its integrity. So some of the components there, some of the neurons will atrophy, will die basically, and the child will not have those neurological components useful. So what happens is that the brain would start to compensate for those lost parts of the neurological component. And this is called plasticity, which I'm sure some of you are aware of, the ability of the areas around the injured area to take on the responsibilities that were supposed to be done by the injured areas. So the brain would try to sort of fix its own problem by compensating, by trying to take over all the functions that were lost. And this is a very positive thing, because spasticity helps the child try to acquire and try to develop all the movements that they couldn't because of the injured neurological component. But the problem is that because this happens gradually as the child develops, then the ability of the child to learn different movements would be impacted by the ability of the brain to compensate for those injured areas. Plus, because of the injury on neurological or the central nervous system, most of or some of the muscles will have problems with abnormal muscle tone. And this abnormal muscle tone would interfere with the child's ability to control their muscles. So for a typically developing child, the muscle tone is normal. It's not high, it's not low. But with a child with cerebral palsy, because of the injury to their central nervous system, their muscle tone is either higher than normal or lower than normal, or fluctuating. It goes up and goes down. It goes up and goes down. So this fluctuating or high or low tone would make the child unable to control the movement of their muscles, those specific muscles. And this will cause stereotype movements that we typically see with children with cerebral palsy. It will have the child face a lot of difficulty in controlling their movement and actually achieving the function of their movement. Add to that the muscle tone and the lack of typically developing movements will impact the coordination and the co-contraction of the muscles. So the muscle groups will not contract smoothly. So we'll have jerky movements. We will have stiff movements. It's not a smooth, coordinated movement. And that's the second component of the overall motor control the child with cerebral palsy will have. The last component is postural control. Because of the injury on the central nervous system, some or maybe all in some of the children, primitive reflexes do not get integrated into the brain quickly. So we know that typically developing child will have a set of primitive reflexes that they will integrate within the first year of their life. And this is when their actual controlled movement or their conscious movement will replace those reflexes. For a child with cerebral palsy, this process doesn't happen smoothly. So what happens is some of those reflexes remain active even after 1 year or the age when the child should have integrated those reflexes. And those reflexes will interfere as well with the movements of the child. So when the child tries to reach for something, the reflex that still exists in their body would make their reaching movement more difficult. Those three aspects that I talked about, the muscle tone, the incoordination of movement, and the postural reactions that are abnormal because primitive reflexes still exist. And of course, the righting reaction, the equilibrium reaction, and the protective reaction did not develop correctly. The child will not have postural control similar to a typically developing child. They will not be able to raise their body correctly and then free their arms so that their arms can reach and move things closer to them. They will not be able to roll from supine to prone smoothly in a functional and easy way. The movements that they will have, as we can see in these pictures, they're stereotyped movement that are impacted with the spasticity or with the fluctuating of the tone or with the low tone. And it makes the movements look different, but also the purpose of the movement is very limited. So the child wants to reach for something in front of them, but their muscles are not helping them. The stereotype movements are hindering this child. The postural control of this child, does not allow him to reach forward. So that's why we see the child with cerebral palsy moving in a very stiff, uncoordinated, unsmooth movement, and often they need support to sit up or to even stand up correctly. And this impacts their function, okay? So I do hope if anyone has any questions, they will just jump in and ask them. Okay, so what are the different types of cerebral palsy? When we look at child with cerebral palsy, we try to examine three things. So those are the three things that we look at to say whether this child have this type of cerebral palsy or another type. We look at the type of movement disorder that they have. We look at which body parts are affected and the severity of the movement problems. So how severe are their problems? We try to, what we do typically is we look for these problems as early as possible. And this is where early intervention comes in. So the earlier you can work with a child with cerebral palsy, the better it will have an impact on their movement on the long run. A child with cerebral palsy should be diagnosed as soon as the impact on their central nervous system is seen. So if this problem happens during pregnancy or during birth, the doctor will know for sure that this child will have cerebral palsy. If they don't know, the first few months would show there are some delays in their motor development, so in reaching the milestones that they should reach. And we say, there are some different views about this, but typically any problems with motor control due to hypoxia, which is a problem in oxygen reaching parts of the brain, younger than 2 years, then the formal diagnosis is cerebral palsy. I know some other people, some other scientists, some other diagnostic doctors would say, no, it's up to 4 years. So I'm guessing now with what we will see in Gaza, for example, we see a lot of children under the age of 4 years who had some brain injury, and they sort of started to develop motor problems. So if we want to decide whether this child has cerebral palsy or not, we need to look at those three aspects. And I will talk now about these three aspects in detail. The first area we will look at is the movement disorder. So movement disorder means that there's a problem with the movement of the muscles. So what we are looking at here is the muscle tone. And muscle tone has mainly two types. So there's the spastic cerebral palsy, which have stiffness or tightness in the muscle, which is hypertonicity. The muscle tone is really high, and the child would show, and we would see that the arms and the feet and the hands are all stiff. The movement of the muscle is tight. What we do typically to examine this is we move, for example, the arm, we move it quickly and suddenly, and we feel with our hands if the muscles are contracting and getting really stiff, and if there's a lot of resistance for my movement as a therapist. So I hold the arm of the child and I move it quickly and suddenly, so that I am trying to see how the muscles will react to this movement. If there's spasticity, I would sense a stiffness, the arm or the hand, or even I can do that with the leg. The muscles would stiffen, and I would feel that the muscles are not moving with me. I would actually have resistance in moving the limb. So this is the first type, and it's the feature of it is high tone. The second type of movement disorder is dyskinetic. Dyskinetic is when the child have involuntary movement. So it's not high tone, it's just fluctuating of tone. So sometimes you get the muscle to get a lot of of spasticity or hypertonicity, really. Hypertonicity, and then it becomes lower. So the movements of the arms is not controlled. The child would be, well, there are different types of it, but in one type, which is the athetosis, the child would be sitting, rest position, not trying to move, and still their hands and fingers and even the feet and the head, they would be moving, okay? This is for athetoid while in resting position. For ataxia, which is the second type of dyskinetic, is when the child have a tremor when they are trying to move. So in resting position, we would not see anything. The child would not have hypertonicity. The child would not have involuntary movement. But once they try to attempt to reach for something or to move their leg or to stand up, but mainly with their arms, we would see that there's this intentional tremor. So we would see the tremor happening, and there are degrees of it depending on the impact in the cerebellum, actually. But we will see a lot of tremor in this movement. So that's ataxia. The second type of dyskinetic CP is dystonia, and this is a very it's a very difficult type to work with. And it's easy to mix it up with spasticity, spastic CP. Dystonia is when the child is having fluctuating tone. So they go from normal tone up, very high tone, hypertonicity, and then the tone gets stuck really high. So they get this movement, the stiffness, but the stiffness continues for a few seconds. And even the child cannot release their arm, okay? So this stiffness is so severe, it looks like a spasm. Do you know the spasm is when you're exercising and suddenly your muscles get so spastic and they're really painful and you cannot move them. So dystonia is slightly different from spastic CP because it's a fluctuating of tone. It's not hypertonicity all the time. Okay, it's normal tone that goes up, gets stuck for a few seconds, and then it releases, and it's involuntary. It happens regardless of what the child is doing. So regardless if the child is resting or moving, but when they start to move, so there's an intention to move, these involuntary contractions happen faster and for a longer period. But even while they're resting, we would see it. Okay? There's the small part of cerebral palsy, which is a mixture of different types. So you might see spastic dystonia. So the child have a general spasticity in their body, but also they would sometimes have involuntary muscle contractions. Okay? And that means that we have a mixed type. I want to say also that we do see children with cerebral palsy who are characterized as low tone, so hypertonicity. And this typically happens in a very young age. So from birth up to, I don't know, 1 year, 1.5 years, even 2 years, the tone of the muscle of this child would be characterized as low tone. What happens typically from what we see in practice is that this hypotonicity would increase as the child grows older. So most of them would either develop hypertonicity, they would develop spasticity, or they might even develop athetosis, okay? So early in their lives, so from birth for 1 year, 1.5 years, I think I've seen a child who's about 2 years, but just started to have hypertonicity. They would have low tone, that the mother would tell you, I cannot move. The child doesn't really move. When I hold my child, it's like holding a doll, okay, very flaccid. But as they grow, as they start to move voluntarily, then the tonicity of the muscles would change, and it would either become spastic or dyskinetic. Okay. The second way for looking or distinguishing between the types of cerebral palsy is the body parts affected. So, and this is specifically for spastic cerebral palsy. For dyskinetic, fluctuating of tone, it is general in the whole body, okay? But for spastic cerebral palsy, we might have a variety of different types. So we would have, for example, hemiplegic, which is half of the body on the same side of the arm and feet. They will have hypertonicity. They will have moderate to severe spasticity. We would see that the second half of the body is completely normal, okay? But we would see the stereotype movement, and we would feel the spasticity when we hold the arm or the feet of the child on only half of the body. The second part, or the second type, is diaplegia. Diaplegia is when the feet are more affected than the upper extremity. This is to say that we might see the child with severe or moderate spasticity in the lower extremities. We might see the upper extremities with very minimum problems, so they can move. The stereotype movements is not seen clearly. We might even see it only when we go into fine movements, so very fine movements and motor control. That's when we see that the arms are affected. Or we might actually see that the effect of the upper extremity is moderate. So we see that, yes, there are stereotypes, but they are not as severe as in the lower extremity. The third type is quadriplegia, and this is the most common. I think hemiplegia is also common, okay? So hemiplegia, we see it a lot, but also quadriplegia, we see it a lot. And this is the type that we typically use wheelchairs and seating materials to help them, because the whole body is affected. So both arms, both legs, and the trunk are affected. It depends on the child. From my practical experience, I would say here that I typically saw that one side would be slightly better than the other side. Usually the dominant side of the child would be slightly better. You can feel that the spasticity is slightly less than the other half, but still all four limbs are affected. There's also different perspective in how to divide those types. So some therapists would say in the case of diaplegia, the trunk would be normal, okay? But in the case of quadriplegia, we would see the postural control really impacted. The muscles of the trunk will be really weak. But other therapists would say, no, actually, both of them, we would see some part of a motor impact on the trunk. I think someone wants to ask a question.
Yeah, there is Haneen is raising her hand. I will let her to talk to say her answer. Where are you, Haneen? Can you raise your hand? Okay.
اوكي هيك تمام.
يس سامعينك، تفضلي.
ايه دكتورة، أنا
أهلا.
تبعت معك من أول المحاضرة، بس صراحة ما فهمت كتير السباستيك. أنا فهمت السباستيك بس الديسكاينتيك اللي فيه فلكتويتد في الإنتون، هلا الأنواع أنا صراحة ما استوعبت الفرق بينهم.
خليني أرجع لي.
هذا فهمته، بس اللي قبليه صراحة مش كثير.
يعطيك العافية.
شكرا يا حنين. So dyskinetic يعني fluctuating of tone. A tone comes from really normal to really high. Two types. Athetosis, which is uncontrolled movement that we see it while the child is resting, or when they are trying to move. So it becomes even more increased. It's abnormal movement. They have two main types, which is choreoathetosis. I didn't include them here. So choreoathetosis is when the child is like dancing. You would see it distally. Their fingers are moving, their feet are moving, controlled, uncontrolled. The child cannot control it. And then the typical athetosis or pure athetosis, you would see it also proximally. Okay, so you would see movement in the body, you would see even in the chin, in the head, the shoulders, involuntary movement. It happens all the time. Dystonia is when those involuntary movements, when they happen, the body parts get stuck in high tone. So the child would have involuntary movement, but then suddenly they would get stuck in this abnormal stereotype movement. You can't release it. The child cannot release it. It goes on for a few seconds. It's like a spasm. شد عضلي. It happens. It's very painful for the child, by the way. It happens, and then the tone comes down, so the limb is released. So dystonia would have that fluctuating of tone, but suddenly we're high and we get stuck there. Few seconds we're stuck, and then we come down a little bit. So with dystonia, you would see that the child is sometimes having involuntary movement, but suddenly we see this. And then the child releases. Okay? Does that make sense, Haneen? Give me thumbs up إذا إنك فهمتي.
Yes, she said yes. Clear.
تمام.
Thank you.
So we know these different types. When we want to see this clinically, we want to make sure this is spastic, okay? And if it's spastic, then we have to decide which type of those are we looking at. I think we have someone else, Sabrine, right?
Yes, I'll let her talk now.
Yes.
I think, yeah. Okay.
مرحبا دكتورة، كيفك؟
هلا.
هلا أنا بشتغل مع السي بي، تمام. بيجيني complex cases وبيكون عمرهم كبير من 8 وأطلع وما صار عليهم intervention. فهلا بالبلان تبعتي هل إنه لازم أركز cognitively أكتر من إنه physically كونه ما في intervention والطفل أخذ هاي الوضعية، ولا أتدخل physically وممكن يصير في progress؟
هلا it depends صبرين. it depends على الديفورميتيز اللي صايره مع الولد. هلا secondary لكل اللي احنا بنحكيه بيصير في عند الطفل cerebral palsy contractures اللي هي تشوهات بالاوتار، بتشد الاوتار، ببطل في عندنا مدى حركي، او حتى عندنا تشوهات بالvertebral column. حتى العمود الفقري بصير فيه تشوهات، سكوليوسيس، كايفوسيس إلى آخره. هلا لما يكون الطفل السيربرال بالسي مرق عليه سنوات وما نشغل معه ونشتغل معه بدرجة محددة، بيكون الريسك كتير عالية إنه صار عنده secondary deformities. هلا إذا أنتي إجاكي طفل بهذا العمر ولقيتي إنه عنده secondary deformities، ضروري جدا إنك أنتي تشتغلي وزائد تعلمي الأهل stretching exercises علشان ما تزيد هاي الكونتراكتشرز، وتعلمي الأهل وإنتي كمان بجلستك تشتغلي على موضوع الموفمنت، لأنه الموفمنت بتقلل من السكندري ديفورميتيز والبوستشر تبع الطفل. بس الأشياء اللي أنت عم تسألي عنها اللي الكوجنيتيف والبرسبتشوال والسنسوري هي سكندري، حكيناها بالبداية، هي سكندري للموتور ديسفانكشن. فلما بيجين الطفل كبير بالعمر أنا رح أتوقع إنه هو developmentally ما قدر يحصل التطور الطبيعي للcognition والperception والsensory وحتى الemotional development. فأنا بدي أصمم البرنامج تبعي بالpriorities تبعوني. priority 1 ما تزيد الديفورميتيز. priority 2 البوستشر تبع الطفل لازم يكون سواء باستخدام الأدوات المساندة والويل شير والسيتنج، أو بالسبلنتنج كمان ممكن نستعمله، بالمعينات الحركية مختلفة. بدي أتأكد إنه البوستشر مناسب للطفل، إنه يقدر ياكل بطريقة صحيحة، يقدر يدرس بطريقة صحيحة. وزائد الانترفنشن تبعي بده يحاول يعوض هذا الطفل بالتأخر اللي صار عنده من ناحية الكوجنيشن، البرسبشن، حتى الايموشنال ديفلوبمنت. منطقية صابرين؟
يس، بس بيجوني كتير كومبلكس على الآخر يعني.
يس، هو كل ما بيكبر العمر للأسف، أنا عشان هيك حكيت بالبداية عن التدخل المبكر. مع السيربرال بالسي التدخل المبكر بتلاقي فروقات شاسعة فظيعة جدا. كل ما بيكبر الطفل بدون ثيرابي، كل ما بتصيري زي كأنك بلشتي أنت بخط مشاكل، صار تراكمات بيجيك الولد عنده جبل مشاكل. اوكي،
يس.
هاي الجبل المشاكل انت ما بتعرفي من وين بدك تبدي. في اشياء بتضطري تقولي ما راح اقدر اساعده فيها، اوكي، لانه يعني في كتير اشياء صارت فوقيها لاوصلها مش راح اقدر الحق. اوكي، ف you have to prioritize. you prioritize your
اوكي.
work دائما safety. اوكي، والديلي الفانكشن تبع الطفل، هل قادر ياكل بطريقه صحيحه، هل قادر يؤدي مهاراته اليوميه صحيحه، وبعدين اذا معي وقت بصير اشتغل على الاشياء الثانيه.
تمام، ثانك يو.
اهلا. اوكي، في حدا تاني ولا نكمل؟
I think no one raising her hand. Yeah, we can continue.
تمام. So for me, when I work with children with cerebral palsy, I typically don't use standardized assessment with them. What I do is I use my clinical observation. So the three components that I told you about, the two components, the movement problem, the body parts involved, these both of them, I assess them by my observation. Okay, so I look at the child, I hold the arms, the feet, I move them, I watch the child while they're moving, while they're trying to do anything. And from my observation, I establish if it's spastic, if it's dyskinetic, and then if it's spastic, I look at the child, move their body parts to see if they're hemiplegic, diplegic, quadriplegic. I want to say also there's the triplegia, which is 3 types involved, or monoplegia. Some people, some therapists, they use these terms, but the typically used are these 3 different types. The severity of the movement is the third observation I try to make. So how severe are those movement problems? There's the gross motor function classification system, which is available for free. It's a very helpful classification system so that you can decide which level is the child at. There's another one for hand functions as well. I'll send Noura, hopefully if she can put them somewhere for you guys if you cannot find them. But if you search the gross motor function classification system, you will find this table with the 5 different types. The 5 different types tell us that in level 1, level 2, the child walks independently. The difference is that the walking of the child in level 2 is slightly, you can observe some difficulties with the movement. Sometimes they might use a crutch. The third type, they need walking frames or elbow crutches, bilateral. The fourth and fifth type, they need to use wheelchairs. The fourth, they can use a manual wheelchair, so they can actually move themselves for short periods of time, for short distances actually. Level 5, they need someone to push them. So they are dependent in terms of mobility. I like to use the GMFCS because it helps you monitor the progress of the child. Okay, so you can easily classify the child, and then while you're working with the child, see if you can move up. It is for gross motor function. There's another one for fine motor function, and it's also available free. Someone asked if I am going to share the slides. Yes, I'm going to share them. I'm going to send them to Noura with those classification systems, the one for gross motor and the one for hand function. I think there's another one. The third one is about ADL. I have to look for that one. I'm also going to share with you guys this book that I really like, which is it targets the parents. So you as a therapist can use this book to help parents with cerebral palsy children. Okay, so that's also part of the things that I'm going to share with you. And most of my slides are from that book, by the way.
I would like to remind everyone that we have a Google Drive, that we put all the slides and additional information, and also voice record for these webinars. And we also have a YouTube channel where we post the recorded webinars. Thank you so much.
Tamam, thank you. I used the time so that I can turn on the lights. Sorry. So yes, okay. So I would start talking about the different features of cerebral palsy in details, but I don't want us to spend a lot of time on this. You can read them. It would be available on the slides. I would like us to move more towards the practical aspect of today's workshop. So I only put those so that we can look at them quickly and just have a general idea of what we are searching for when we want to say this child has spastic cerebral palsy, severe, moderate, or mild. It's a different type of characterization. So a child with severe spastic cerebral palsy, we would see that they have exaggerated co-contraction. Co-contraction means when two opposing muscle groups work together. So you have the flexors and the extensors. When we move normally, it's not just one group of muscle that's moving and the other is completely relaxed. No, both of them are contracting, but they co-contract. One contracts a little bit more than the other one so that our movement would remain stable and smooth. Okay, so with children with severe, which is the most difficult type of spastic cerebral palsy, their co-contraction is really exaggerated. So both muscles are spastic, and so the body part moves in a very stiff way, and you can literally see the child struggling to even achieve full range of motion. The tone is unchanged. Even when we change the posture of the child, we still see the stereotype movements that the child have, and we still see the stiff limbs really fixed and very spastic. We see tone more or increased more proximally than distally. The child with severe spastic CP, they don't do a lot of active movements. They move in limited range, typically midline and somewhere close to them. So they don't reach out away from their body. They don't really move in large ranges of movements, just small and short movements. That's why we see with them a lot of secondary deformities, a lot of problems and deformities in the vertebral column. Okay, a lot of contractures because the movements are very limited. We also see that they have, I said mid range. We also see difficulty in initiating movement. When we move them, when we handle them and carry them from one place to another, the child would be really, let's say they're not really relaxed, and they would have a problem in adjusting to this movement. Balance, protective reactions are really poor, no or poor writing reaction, and we see a lot of associated reaction. And for those who are not familiar with associated reaction, it's when you move one body part because you're trying really hard to move it, another body part of your body would also contract. We see that when we're trying to open a really tight jar. So when we move it, we can, squeeze our teeth. I always say that girls do have associated reactions when they're putting on their mascara. So you unconsciously start to move, to open your mouth. This is associated movement, it's normal, it's acceptable. Associated reactions is when this is happening for the child with severe spastic cerebral palsy in an exaggerated way. So they want to hold the pen, they want to move the pen with their hand, you would see the other hand moving as well, okay? So it interrupts bilateral control. So the child will not be able to hold things bilaterally, or when we have an activity where the child needs to stabilize something and move the other hand, they will have a lot of difficulty. The moderate spastic, we would say a little bit changing of the hypertonicity. We can see that the child would have the higher hypertonicity when they are stimulated. When they are rested, we would see lower tone. When they are trying to move, we would feel the muscle tone change and become really high. It will be related to stimulation, effort, trying to talk, or even when they are really upset, when they're crying, when they are startled, when they are scared. We can see that the hypertonicity is going really high up. We have poor balance, we have poor protective responses. It's more distal, the hypertonicity, than proximal. Associated reactions are also seen here. The child can move, but they would move with stereotyped abnormal patterns. So the flexion pattern or the extension pattern in their lower extremity, this is what we would see. And they are moving using these patterns. So they reach while doing the flexion pattern. They're likely to be compensatory. So they're compensating for their movement, for the lack of free movement, by using those stereotype movements. So when they want to do something, they have to compensate. Choreoathetosis is when we see fluctuation. This is now dyskinetic. We're not talking about spastic now. We're talking about athetosis. So involuntary movement. We see constant, all the time, fluctuating of the tone between abnormal and high. We see involuntary movement. We see difficulty or inadequate co-contraction. The child will have a problem with the postural control, and it's typically asymmetrical. So for me as a therapist, honestly, when I want to see if the child is spastic or athetoid, I look for symmetry. Symmetry, I would see it in quadriplegia, diplegia, severe or moderate. But I will not see symmetry with a child with athetosis. So if the child is in a asymmetrical is one side is doing movement and the other is doing another movement, or in their posture, they look like if you cut them in half, you would see one part doing one specific movement, the other doing the other movement. This is typical of athetosis, okay? Because the involuntary movement that they have is asymmetrical. So this is one clinical observation that will help you point out that this child has athetosis. And of course, the involuntary of movement. The child dislikes to stay still. This is another feature. If you put the child down on the mat, on the floor, they would not sit still. They would keep moving, okay? Because they cannot sit still. They have involuntary movement. So this is one key for you. If you see a child with cerebral palsy who keeps moving, even while they're sitting, they keep moving, this is a cue for you that they have athetosis. Choreo specifically is distal more than proximal. So they used to say it looks like they're dancing. So they're moving their fingers almost like they're dancing. And dystonic, I said before, they have proximal fixation. The tone stays high for several seconds and very, very high. Spasms, this is the distinction for dystonia. There's a spasm. You can feel that the muscles are in spasm and they're fixed. There's no purposeful pattern for them. It's very asymmetrical, and they have a lot of contractures and deformities. It's very unfortunate, but we see it common with dystonia that they have scoliosis, or they have limited range of motion in certain in certain joints, really. Older children, they show more spasticity, and they almost can look like spastic quadriplegia, but we would still see involuntary movements there. Ataxia is when the injury in the central nervous system is limited or focused more on the cerebellum. So we're talking about balance, we're talking about coordination. So in resting position, the ataxic child will not show any features. You would think that they look weak, their muscle looks weak, okay? Almost like some different diagnosis, which is called muscular dystrophy. But when they start moving, you would see clearly they have a problem with coordination. They have a problem with the intentional tremor. So once they start moving, you would see the tremor happening. When they stop moving, the tremor is gone. Okay, so this means it's an intentional tremor. And the balance is really clear. So if they're walking, and they typically have no problem, so they can actually walk, but when they're walking with wide base of support. Their gait is characterized by them walking with really wide base of support, and they're almost all the time trying to save themselves from falling. The parents would tell you they keep falling, they keep hitting things. They have a problem with balance because the cerebellum is affected. And grading of movement. So when they want to do a movement, they don't estimate the speed, the distance of their movement. So they either overshoot or undershoot their movement. Hypotonicity or low tone is, as I said before, their tone is really low. They don't really have they don't have trunk control or head control adequate enough for them to sit up. They don't move a lot. The muscles can even be hypermobile. So the joints are more than the normal range of motion. They don't really respond. You see that the child is really sleepy, they're tired, they almost not responsive to you, and they typically have associated problems like poor vision, hearing, speech, and a lot of feeding problems because we don't have head control. Okay, now we will start to look at observation. I'm aware of the time. Okay, so yes, that's good. We have 1 hour for this. When we want to observe the child, we need to observe the 3 things that I told you about. The movement problem, the, what did I say? The movement problem, the type of movement, the body parts affected, and the severity. We see those in observation. Okay, we observe the child. We handle the child as well. We handle the child meaning we hold their arms, we hold their legs, and we move them in certain ways to see, to feel, because spasticity specifically, you feel it with your hands more than you see it. Okay, so if you don't hold the arm or the feet or the legs, you will not be able to feel how stiff the muscle is. So you need to let your fingers feel those things. Okay, so we observe the child in different positions. If the child is really small, we start observing them when the parents are holding them, when they're sitting in their parents' lap. We might ask the child to go and sit on a stool, which is a chair without the back, so that we can see the posture, their trunk control. I really like to start off with a cerebral palsy child. The first time I meet them, I always go and we sit on the floor. And when we sit on the floor, that's where I see the child moving. And I start to ask them to do different movements. So turn on your back, turn on your stomach. Let's do kneeling. Let's move like a cat. And then I start to look, and I start to reach for the hands and the legs and to see what's happening there. Okay. Sometimes if the child cannot stand, I hold the child up in standing and try to see if they can maintain that or not, and what's happening when they are put in standing. While the child is moving, I also look for how they change from one position to another. So this changing from one position to another shows you a lot of the abnormal stereotype movements that we look for. While I'm observing the child, this is all for assessment, yeah? While I'm watching the child, I'm looking for the type of support he needs, the movements that he has, the quality of the movement, what can the child do, what the child has difficulty in doing. Does he do a lot movements in an abnormal way? Okay, so stereotype movements. I look for pathological symptoms, so involuntary movements, asymmetry, stereotyped pattern of movement, or some of the primitive reactions that or reflexes that are still there. So I look for the startle response. Okay. I look for the asymmetrical tonic neck reflex. I look for the grasp reflex. These are all of them primitive reflexes that might still be there with the child, even if they are years old, okay? Because of the impact that the central nervous system has. So, and I also look at how the child is behaving. So are they moving freely? Are they relaxed? Or are they troubled and annoyed? In these slides, there are some of the things that you can look at. So you look at how the child is sitting upright, or are they leaning forward, or are they leaning backward to their parents or the chair? If the parents are there, we need to see how the parents, this is for home-based intervention, we need to see how the parents are providing the support that the child needs. So where are they holding the child? Do they support the trunk, or do they support the shoulders, or do they overwhelm the child with their support? Because we need to fix these ways that the parents are supporting. If it's not functional, if it's not helpful to the child, we need to fix that. We need to look at how much movement the child is doing and which parts are moving. Does the child have the ability to stay still? Remember, athetosis. So if they cannot stay still, then we suspect that they have athetosis. And what are they doing with their arms? If the child is sitting on a chair, we look at the type of support that they need, the alignment of the trunk. Are they sitting on the sacrum? And sacrum sitting is when the child is sitting not on their bum, but they're sitting on the lower of their back. Okay, so you see the whole back is like a C shape, and the child is not sitting on their bums. They are actually sitting. You can see that the back of their the lower back of their the lower part of their back is actually where their weight is going. This is called sacrum sitting, and it's very troubling. For a therapist, you need to try and eliminate the sacrum sitting, because it will lead to secondary deformities, mainly deformities in the vertebral column, because this is the one that will cause a lot of problems for us. How do we get rid of this? We get rid of this with adaptations, okay? So postural adaptations, we might help the child to sit on a cushion, and then increase the tilting of the cushion so that the child will have to raise their back backwards, so it becomes a bit upright. We might put a little bit of pressure behind, so we use a roll behind the lower back of the child to push the pelvis forward. That also sometimes would help. Do we have any reactions? So if the child is displaced, so their body is displaced, do they protect themselves? Do they help themselves? Can the child use their hand in this position? Or do they use their hands for balance? If the child is sitting long sitting, or they're sitting on the floor, I want to check if they have W sitting, which we can see in this picture. W sitting for a cerebral palsy child will cause deformities. It will cause deformities in the hips, the knees, and the feet. So this is one posture that we need to tell the parents not to use, okay? So try as much as you can to take your child out of this position. If they really, the children will like it, because this is the position that will give them maximum stability, okay? So W sitting, they have a lot of body parts touching the floor, which means that they have stability, and this will compensate for their poor trunk control. So what we tell the parents, typically, if they have a child who continues, cerebral palsy child, who continue to sit W sitting, we ask them always to have a short chair for the child, or to always remind the child to sit in long sitting, and then put cushions to the sides, so that these cushions will give the child the support that they need, okay? We look for the child balance. Are they sitting on their sacrum, the trunk control? Is the weight distributed? Can the legs be adjusted so that they can reach with their arms? Do they take weight on their arms? Can they use their arms for playing? And yes, this is W sitting. So do they sit W sitting or not? We don't like W sitting, okay? Just to confirm, we don't like it, and we try to avoid it as much as we can. If the child insists, then we tell the parents, okay, let them sit a little bit in W sitting, but then immediately ask them to change. So keep changing the position, because changing the position will stretch the joints. So at least the deformities will not be very severe, okay? But we actually like to avoid them at all. Long sitting, which is this one, and this is sacrum sitting. So you see the child is not really sitting on the bum, they're sitting on the lower back, yeah? So this is horrible. This is their vertebral column will have deformities. We will have a lot of pressure on this area, which is not helpful. And also the legs are sitting or extended, but they are also going into stereotype movement, which is a lot of extension or plantar flexion in the feet, and adduction. So both hips or both legs are really touching each other. So this is the long sitting, and it's very difficult for children with cerebral palsy. If we want the child to sit in long sitting, we have to provide support from the environment. So something behind the back, or something on the side, or even something to raise the knees a little bit. If the child is lying on the floor, we would see a lot of stereotype movements, okay? So these movements would depend on the type of cerebral palsy that we have, and whether it's severe or moderate. So we can see this is a typical stereotype of flexion, and here flexion, and we have extension in lower extremity. It's asymmetrical. So it might look like that this child have aphytosis, okay? Does the child roll? When they roll, how do they roll? And what kind of movement do they make? We also put the child on prone. This is all for observation, to see how the child deals with being prone. The first picture is for a typically developing child. If you put them prone, they will immediately raise their head and their upper trunk. They sometimes even place their elbows on the floor. If they're older, you can see this whole picture. You can see them raising their feet up and their arms up, and just the only part that's touching the floor is their tummy. If they're a bit older, if they're younger, you might see only the upper trunk. A child with cerebral palsy, specifically spastic children, will not be able to raise their hand a lot, so head. So you would see that now the visual field is limited, and you would see that the feet are going into extension and the arms are under the trunk. Okay, so this is one distinction for us to see if there's a normal pattern of movement or not. When we put them in standing, we would immediately see a trigger of some of the primitive reflexes. So this is the stepping reflex. The stepping reflex is triggered when the feet, the bottom half of the feet or the arches of the feet, they touch the floor, so they trigger the stepping reflex, and the child stands on their toe. They stand on their toes, but also in adduction. Okay, so almost like their feet are, or their knees are crossing each other. We see also the arms going into flexor pattern. So this is typical if we held the child in standing. Yeah, we look at how the child deals with standing, where they put their weight. Are they symmetrical, asymmetrical? Are they taking the full weight on their legs? Are their knees hyperextended? And then we look at how the sequence of movement, how the child moves from one position to another. Okay, so changing from rolling, from prone to supine, going up into sitting, crawling, moving to standing. And then even when standing, do they hold on to something, moving or stepping sideways, which we call cruising, stepping forward with support, or with hands being held, or walking alone. So all of these are sequences of movement that we look for. We hope to reach that point where we can take the child from one sequence to another. Okay. Okay, all of these are explanations of the different sequences of movement. So you can look at this later on. I think that they're pretty clear from the pictures, how the child would do sitting up from supine, how the child will change from sitting to crawling. These are the type of things that we look at. Crawling itself, it might be as bottom shuffling, which is here, or bunny hopping, which is shuffling symmetrically. So like a bunny, like a rabbit, that's hopping. And this is pulling to standing. And then from sitting on the stool, we stand. So we look at all those different types. I have those information for you to read later. I want us to move to handling, so that we can have a little bit of some practical things to teach the parents. The basic handling techniques are principles that we need to teach the parents who have a child with cerebral palsy. Specifically, some of them would be for spastic, some of them would be for athetoid, or even for low tone. But we always want the parents to know that when you are carrying your child, when you're handling means you're taking one part of the body of the child and trying to move it some way to correct the posture of the baby. We need to tell the parents that they need to do this correctly. If they don't do it correctly, then they are encouraging stereotyped movement, and they are not helping the child develop normal sequences. The first thing, the most really essential part, is when we want to lift the head of the child. So lifting the head of the child, if we typically want to lift a child who is typically developing, what we would do is we would put our hand underneath the head and lift the head up. This doesn't work with a child with cerebral palsy, because once you have your hand behind the back of the head and the neck, you are triggering a reflex which will push the head backward even more. Okay, so the typical way we lift the head of a baby will not work with a child with cerebral palsy. What we want to do is what we see here in this picture. We want to hold the head of the child sideways, so above their ears, and we want to push with our arm. We want to push on the shoulders here and lift the head. We try our best not to touch the back of the head or the back of the neck, because that's how we trigger the hyperextension of the neck. So this is very important for the parents to know. If we want to raise the head, if the mother wants to raise the child's head to put a pillow underneath, or she wants to do this so that she can lift the child up, some of the mothers struggle to lift their child, because once they try to carry the child, once they put their hand underneath the head, the child would shove their head backwards, which really scares the mother. So this is one of the techniques that we need to teach them first. When the child is sitting in our lap, we want to control the child so that the child does not fall away from the parent's lap. So what we do is we want to hold on with the child, but not trigger this reflex that I told you about. So if the mother would put her hand behind the child's neck and back, they would shove backwards even more. So this is scary, because then the child would fall off the chair or the mother's hand lap. So what we want her to do, not this one, this is not good. This is the one that we want her to do. We want her to put her arm behind the shoulders. Try your best not to touch the back of the head and the back of neck, just behind the shoulders, and then try to pull the shoulders together to the midline. This will help the child to sit with their shoulders to the midline. This is specifically important for children with athetosis, because what they do is they are away from the midline. They have their involuntary movements here. So the mother wants to hold them in her lap and bring the arms to the midline. So we tell her, don't use your hand on the back of the head, put it behind the shoulders of the child. We want also to help the parents or the mother with low postural tone. So the child with hypertonicity, when they sit, they're like a doll, okay? They either, their head goes forward, they can barely lift their head, or if there's a back for the chair, they will lean backward on the chair and the head will go even further backwards. We don't want that. We want the child to be able to have some head control. So what we do is we provide proximal support for the child. The proximal support we provide it with the child using both our arms or hands. We hold the shoulder and we bring them a little bit forward. By doing that, we're giving the child enough stability in the shoulders so they can focus on controlling their head. And this is part of the therapy for the mother to do, because the more that the child would be able to control their head, the more she uses this handling technique to stabilize the shoulders, the child will practice controlling their head and lifting their head up. And this means that their muscles of their neck will receive more stimulation. With time, this stimulation would help in gaining some control over the head. So the child would be able to lift their head independently, okay? So hold the shoulders and try to pull them forward, okay, towards you, so that the child would have the neck and head free so they can control it. And then we have some difficulties with child who have increased postural tone. We want them to raise their head because their typical posture, the posture that they are sitting in, is this is spastic child, okay? What they're doing is they're doing stereotype movements, so they have flexion pattern in both arms, and their shoulders are protracted. Protracted means they're going forward, and they are raised a little bit. So this means that the child has their arms stuck here. They also don't have a lot of head control because their head is also leaning forward. What we are going to do is the opposite of the low tone. We want to hold the child above the elbows, and we want to push the shoulders back, okay, while turning the arms in external rotation. This will give the child, it will release the pattern from the shoulder. So the pattern is flexion in shoulder, elbow, wrist. When we break it, when we move the shoulders into a slight external rotation and a little bit of flexion, and we push backwards, then we are sort of breaking this pattern. We're breaking this stereotype movement pattern, so the child will be able to extend their elbows and even open their hands, as well as they would gain a little bit of head control. Again, this is type of intervention. So we're teaching the parents to do these things all the time, okay? Sort of an exercise that they do at home more than once, so that the child with time will develop more head control. With a child with low postural tone, we want them to, or with athetosis actually, we want them to sit independently, and we want them to have good control of the head and raising or bringing the head forward, because it's really to the back. So what we do is the opposite of this one. We still hold the arms above the elbow, but instead of turning them out, we're turning them in and we're pulling towards us. In the other one, the previous one, we're turning outward and we're pushing backward, okay? In this one, we're turning inward and we're pulling towards us a little bit. By doing that, we're allowing the head we're allowing the child to have more control over their head and their neck. This is another thing, a key handling technique that we need to teach the parents to prevent deformities in the future. So one of the main stereotype movements that we see with children with spastic cerebral palsy is the posture of flexion. So the flexion pattern. In the flexion pattern, the thumb of the child will go inside, touch the palm, and then all of the fingers would be curled above it. And then we have flexion in the elbow, in the wrist, flexion in the elbow, and even sometimes we have adduction. So what the parents do, they want the child to open their hand. So what they do sometimes is they take the thumb out, as we can see in this picture, and they pull it out. This is very harmful. It will cause the dislocation in the thumb. It's very, very harmful. It doesn't happen immediately, but the more they do it, it will cause the joint in the thumb to become very laxic. So the tendons will be weak. So we will have subluxation or even dislocation in the thumb. So we want to tell the parents, don't do this. Don't start fixing this posture or this pattern from the thumb. What you want to do is to fix it starting from the shoulder. Okay? So the first thing you do, one hand will hold the hand of the child. We don't care about the thumb. We just want to hold the hand. Okay? The other arm of the mother would be on the elbow. and we try to open, but as we're trying to open it, we're actually focused on the movement of the shoulder. So we're trying to do abduction in the shoulder, we're fixing, and as we move the shoulder, we will feel the muscles of the elbow and the wrist relax a little bit. We can do this while pulling the arm a little bit. While pulling it out, we're actually stimulating traction in the joints. And tractions, typically in any joint, will help the muscles to relax. Okay, so we tell the parents what you want to do is you want to open all the arm, but you should start from the shoulder. The movement should start from the shoulder. You will see the effect on the elbow and the wrist and the fingers. You can continue, if you want to do therapy as well, or you're teaching the parents therapy, you can continue to raise the arm up, as you can see in the picture. And this is when we start focusing on the fingers, because we've done the shoulder, we've done the elbow, they are extended, they are released. This is when we focus on the thumb. So we're still not touching the thumb from the tip of the thumb. We're touching it, or we're fixing it from the proximal aspect, okay? So as you see the fingers here, they're pushing the thumb out and the fingers out, and we're doing extension in the wrist. The extension in the wrist with the arm raised up will provide stretching for all the muscles that are typically flexed. So we're actually stretching all of it. I personally like to continue this by also doing a pulling upwards of all the joints. So traction again, I pull, and that's when I feel the muscles relax. You can also do it in a different way, which is after you've extended the fingers and the elbow, you can put the hand on the floor or on a table so the child can do weight bearing on it. Okay, weight bearing is beautiful. It's the one way of relaxing the muscles and going against the stereotype pattern. Okay, because just by putting weight on an extended arm, we're stimulating the joints to help the muscles relax. So we do that for the upper extremity. For the lower extremity, we see the typical pattern is in this picture. We have adduction in the hips, we have internal rotation in the hips, we have slight flexion. It's mostly extension of the knees. We have plantar flexion in the feet, and even the toes are in flexion. Okay, and the adduction, sometimes it goes even as crossing, so the knees cross over each other like a scissors. The parents, when they fix this, so when the mother wants to help the child get dressed, so put on their underwear or their pants, or even change their diaper, the mother would hold the legs from underneath the knees or above the feet and just start pulling the legs in abduction. This is wrong because this will increase the spasticity. It's like sending a message back to the brain to resist more. What we want to do is to break the pattern. So how do we break the pattern? We teach the mother to put her arms above the knees, not directly on the knees, just slightly above the knees, and start by doing external rotation, okay? And then pulling away. So the external rotation at the beginning will really help in breaking the pattern. It's sending a message to the brain to relax. So it would be easier for her to control the legs in this way. When she gets the feet apart, she can do whatever she wanted to do. So change the diapers, put on the underwear or the pants. But this is the way for her to relax the feet of her child. The toes, this is a pattern, or this is a problem that the parents would have when they want to put the socks and the shoes on. They want to put the shoes on, but the toes are going into flexion. the feet are going into plantar flexion, so you can't push the shoes. You can't push the foot inside the shoes. Okay, so what they might do is they hold the toes and they extend. Wrong again, because that's increasing the pattern. What they need to do is they need to put the heels of the foot with their fingers, and then let the toes rest on the rest of their hand, and then try to slowly push. Okay, by pushing the toes upward and pulling the heels. So they pull the heels and they push the toes. This is how they get the foot to flex a little bit. And this is when they can put on the socks, they can put on the shoes to help the child or to dress the child. Children with quadriplegia, spastic quadriplegia, they would typically lie on their tummy in this way. Their hands would be tucked underneath them. It's very difficult for them to pull their hands out. They get stuck in this position. So if we want to help them, the typical way, or the way that people think is correctly, is by holding the chin up. This is not enough, because when you hold it up alone, you're actually triggering more flexion in the arms. What the parents need to do is to do it at the same time. So one hand is holding the chin, trying to go into flexion, but the other hand is holding the elbow and pulling the whole body upwards. This is focusing on the trunk. Instead of doing the movement at the neck alone, we're doing the movement at the whole trunk. After we pull out the hand, we can rest it on the floor so that the child will have their elbow on the floor, and we can move to the other hand. This is how we help the child up. We can go even further to extend the elbow, and when we extend the elbows, the child is resting or leaning on their hand, not on their elbow. Okay? So this is another way for us to help them. I like to do this to teach the parents when they want to put something underneath the trunk of their child. So like they roll up, I don't know, a blanket or even a pillow, and they put it underneath the trunk so that the child will raise their trunk a little bit, and then they can use their hands freely. So this is how we teach them to do that. If we want to put the child on a roll, if the child is small, so small sized child or baby, then we can do this by one person. One arm would be underneath the shoulders and helping the arms to go into this posture. So one arm would be into external rotation, and the other one would be raised up. And the parent would try as much as they can to, with the other arm, to try to pull the feet or the knees away from each other. Once we do this, we can carry the child and put them on a roll. Sometimes when the child is sitting in the lap or on the lap of their parents, we want them to give the child some stability. So instead of giving them too much stability, so holding the child completely, which prevents the child from using their arm, we tell them to just put your hand on the hips. By putting your hands on the hips, you're allowing the child's hands to move. So either to rest on your hand or to even rest on your knee. If the child is a little bit bigger, so instead of sitting on the parent's lap, they want to sit on a chair, we can sit behind them and just give them a little bit of support on the hips to fix the hips. You remember the sacrum sitting? So just pushing the hips forward so that the child is not sitting on their sacrum, they're sitting upright. This will provide enough control or enough stability on the pelvis so that the trunk would be extended and the child will be able to use the hands for any activity we want. When the child is in the lap, never put the legs of the child around both your knees. try always to put the child on one knee while holding the child, either from the hips, or if the child is not really stable, then from underneath the shoulders. So this is giving the child enough abduction to have stability. When the child is sitting with both their legs around both knees, they have a lot of extension in their hips. It triggers again the startle or moro reaction, which is the one where the child is scared. Okay, so we want a little bit of abduction here, but not too much. When we want to sit on the floor, or the child wants to sit on the floor, we need to fix the way they're sitting. So we don't want the feet to go into internal rotation. So we instruct the parents to always fix them so that the hips go into external rotation by putting your hands on the insides of the thigh and just pulling away and turning the feet. If the child is a bit older, you can put your hands on above the knees and turn. This will help the child get stability because we have wider base of support, but also allowing the trunk to gain some control. Children with fluctuating tone or dyskinesia, they're asymmetrical, as you can see in the picture, and they're not towards the midline. They are actually away from the midline, okay? So their arms go away, their feet go widespread, and they don't have a lot of trunk control. What we want to do the opposite for what we did with the spastic. We want to bring the child into the midline. So we hold the child from the shoulders and we pull towards the midline. I like also to first flex the knees of the child and then bring them to the stomach so that we put the child in this pattern, which gives them stability, but also controls a little bit of their fluctuating tone. We can also use different sitting postures. So side sitting is good instead of W sitting. Cross sitting, which is terbi'i, nitrabba. We do this if the child's joints and muscles allow us to do this. It's a very good one because it helps the child get a little bit of stability, but at the same time, we are breaking the pattern which the child is typically in, which is the extension pattern. If we're working with walking, then what we do is we hold the child above the elbows and we try to control or to give the shoulders stability by pulling the arms backwards so that the child would raise their trunk and then allow the child to control the rest of their body, okay? Because we gave them stability here at the shoulder level so they can focus on the rest of their body. Okay, is everything okay with everyone? Are you with me? Any responses? So
yes, we are all okay.
Good.
Sorry, I lost the mic.
It's okay. So I'm getting messages from everyone. Okay, I just wanted to check because I thought everyone was sleeping. Okay.
No, it's very clear. Thank you so much.
Okay, so we can continue. The last part of today is how to carry the child. Again, what we did first is how to handle the child, how to move the child, how to help the mother move the child while she's dressing him or while she's trying to fix his position to eat or to wear the socks or change the diapers and so on. Now we also want to teach the mother or the parents or the caregiver how to carry the child, okay? Because carrying the child is very important and it's one of the areas where the parents really struggle, especially if the child has very spastic muscles, then they cannot control the child. It's very stiff. Or if the child has dyskinesia, they have fluctuating of tone, so involuntary movement, and that the parents wouldn't know how to make the child sit still so they can carry it carry them for a long period, and this is essential. We also want to help the parents know how to lift the child. So lifting the child can cause harm to the parents themselves. So when we carry a child heavy and we're lifting them from the floor or from the bed, we're putting all our focus on our vertebral column. So the parent might eventually get complications themselves. So they get injuries in their vertebral column. We don't want that, because then we will end up with 2 patients instead of 1. So we want them to learn how to correctly lift the child, how to correctly carry the child. The first way is if the child is predominantly extended. And by extended, I mean that the pattern they're taking is an extension, okay? They're going away, they're extending their legs, they're extending their arms. So what we want to fix, we want to help the parents by telling them the key point for us here is the shoulders. We want to bring the arms towards the midline. So we use our hands underneath the child's underarm, and then we turn forward. We turn the shoulders forward. Now, the feet need a little bit of help too. So what we can do is with our hand, we can sort of spread the knees a little bit of the child. So we can put our hands between their knees and then fix the shoulder and bring the child up toward us. Okay. If the child is predominantly extended and when we want to lift them and we want to hold them and carry them, we want to give them enough support. So first thing, the first thing I told you was we never touch the back of the head. So you see the mother here, she puts her hand or arm behind the shoulders, not behind the head. And she also puts her hand or arm underneath the knees. And she's trying to, the child is in extension away from the midline, so she's trying to pull him in. By pulling him in from the shoulders and underneath the knees and trying to flex him, flex the shoulders, flex the hips, she is actually controlling the whole body, okay? Another way, which I personally like, is when the child, we want him to see the world, because this is how we promote development of perception and cognition and sensory development. Because if they're always towards our shoulder, then we're hiding the child. They cannot see the world. We want them to see around them so that they can interact with the environment. So we're almost doing the same thing. We're doing a flexion in the shoulders, flexion in the hips. But instead of coming behind the shoulders of the child, we're coming from in front of the chest, and we hold one arm and we pull it towards us. The back of the child is to the parent, and then her other arm is beneath his knees so that she can also again put him in flexion, but the face is still towards the environment. Okay, so this is really helpful to break the extension pattern in the body. Okay, someone I think wanted to ask something. Or they
Yeah,
changed.
I think Farah or let me see.
It looks like they changed their mind.
She changed her mind.
Okay. Now with the child, oh, Hadin. Okay, let me again. No, they also changed her mind. Hadil, do you want to ask your question?
I'll let her able to interact. Yes, Hadil.
Oh, hi. Thank you, Doctor. But sorry, I lowered my hand and I thought just I'm going to ask a question.
Okay.
So, if the child is in permanently extension position, and we want him to explore, and we want her to explore the world around, aren't we supposed to just be stabilizing the trunk and the torso in order for their hands to be, experiencing, experiencing like grasping things from around or touching their mother face. I'm just thinking about how can we promote the experience using their hands without restricting the movement while they are in the extension position.
Yes, this is a very good question, Hadil. Thank you. So what we're doing, we're breaking the pattern at the level of the shoulder. Okay. So if you see the mother in both different types of carrying, here she's bringing the shoulder forward, but she's leaving the elbow and the hand free. Okay. She's also bringing the hips into flexion, but she's leaving the legs, the knees, the feet free. What happens with stereotyped patterns is that if you change at the proximal level, if you do an opposite movement at the proximal joint, the rest of the distal joints would relax. The muscles there would relax. So this is what we call key points of control in NDT. So key point of control is proximal to allow for stability. We allow stability by bringing the shoulder into protraction. So they're always in extended pattern, they are in retraction. They're going backwards, okay, away from the midline. We bring the shoulders into protraction, and we're trying to stabilize the child in this position. Okay. Now the elbows, the hands are free to explore in the midline, because this is the area where the child has a problem. They're typically away from the midline. We want to bring them in towards the midline, and we want to give them enough stability in the trunk and the pelvis so that they can see the environment and focus on their head. So by doing this, by putting the shoulders into protraction and the hips into flexion, the face away to the environment, the child can raise their head. If they want, they can rest it on the back of or the chest of the parent, but they can move their hands in the area which is the midline, which is the problem that the child has. Is that clear?
Yes, that's clear. But I wanna just I have another question.
Yes.
What if we have asymmetrical movement? Is this going to stop the asymmetrical movement, or just we will still have the asymmetrical movement while stabilizing the child?
It's different from one child to another. So if we have asymmetrical movement, we try to focus on the part that is going away from the midline and bringing that in, because in asymmetrical movement, you will have one part going away, one part going into flexion. So we try to provide the stability to the one in extension, the one going away from the midline. It breaks a little bit of the pattern. But your question reminds me to mention one point, which I think I forgot to say it earlier. When we're teaching the parent, we teach them to carry the child, to handle the child based on their child's needs. Okay, it's not a generalized technique. So if the child is going completely into extension bilaterally, we use this. If the child is asymmetrical, I might do some adjustment. I think later on we have one for athetoid, which can work for asymmetrical movements in the child and involuntary movements. But we need to be careful that we need to change those carrying and handling techniques to fit this specific child, okay? Because this is very essential. Otherwise, it might not work with the parents. The other thing we need to do is we need to see the parents perform these techniques in front of us several times before we tell them we are confident that they can use it at home. because when we are watching them, we will fix a little bit of the things that we have. We might, for example, recommend one parent to hold the child in this way because they can handle it and they managed to learn how to do it correctly. But then another mother, she just couldn't handle this. She couldn't control the child. Then we don't teach her this one. We don't teach her the one facing forward. We teach her the one facing sideways because it takes less effort and it gives the child more control. So this is your clinical reasoning as a therapist. Which technique I want to use with this parent and with this child? Okay.
Thank you, Doctor.
You're welcome. So for a child predominantly flexed, we're doing the opposite, okay? If you notice, we are always doing the opposite of what the child typically or their stereotype pattern, because this is how we're teaching the brain to move away from the stereotype pattern and to start to use other patterns. So if the child is predominantly extended, we try to put him in flexion. If the child is predominantly flexed, then we try to put him into extension. And the second rule of thumb, as you say, the second general rule is if we're looking for stability, we're holding proximal joints, okay? If we're looking for mobility, if we're trying to help the child move, then we put our hands on their distal joints, because carrying and handling is all about providing the child with stability. We see that all the techniques I showed you focused on the shoulders and the hips, because this is what we want the parents to give the child: stability while carrying the child, so that the child can move the distal parts on their own. In this pattern, the mother tries to place her, and this is a bit for babies, for the younger children. First of all, we want the child to look to the environment. So we're holding him backwards, so the face is towards the environment. We're helping the mother to carry the child. We show her that she needs to put her elbow on one of the shoulders of the child, and her hand should go between the hips. This is to prevent adduction, okay? So she's sort of holding the child between the thighs so that the child will not go into adduction, which is the dominant pattern. Her other arm is for stability as well. She can also use the other arm to stabilize the shoulder, the other shoulder. If the child is a little bit bigger, then the mother needs to learn to be a little bit more expert in handling this child. The same way, except that she needs to circle her hand on around the upper chest of the child to hold both hands. So one she's holding with her hand and going or bringing the shoulder into away from the midline, and his other shoulder she's holding with her elbow. Again, her other hand is putting the legs into abduction. If she wants to give the child some movement, she can also put him a little bit on his tummy, move him around. This is all for the mother to do, but this is the way we want the mother to control it. This specific strategy needs a lot of practice from the mother. If the child has fluctuating tone, so this is Hadil, to answer your question about asymmetry, we want to put the child in symmetry. Okay, so a fluctuating tone, the child would have one leg abducted, the other in extension, one arm raised up, the other arm in flexion. So we want to put them into symmetry. So we tell the parent, again, you need to flex, and again, fluctuating tone, they're going away from the midline. We want the child to bring the child towards midline. So we flex both legs, and the parents would place their hand on the legs and pull the knees towards the chest of the child. They can put their other arm on the chest of the child, or they can just, as we see here, they can put the each arm on one leg if the child is bigger. But in this position, what we are doing is we're bringing all the limbs toward the midline, and we're causing symmetry here. We're making symmetry happen. If the child, we want to carry him, again, with fluctuating tone, the focus is always to bring the child into the midline. So we're sort of bringing the knees towards the chest, but the child can have the upper trunk free. So if they want, they can hold into the neck of the parent. If they want, they can look sideways. This is another one, and this one I like. Honestly, this is one of my personal favorite ways of carrying a child, because it gives the child a lot of freedom, and the parent gets to use their other arm if they want. So the mother is using her hip to stabilize the child and to put a little bit of a wedge between the legs of the child. This wedge will help the child gain some stability. So at the level of the pelvis, at the level of the trunk, the mother is providing the child with a lot of stability, okay? And she's also carrying the child from his back, so his face is away, the arms are free, the legs are free. So the child can actually be able to move their arms, carry things, play with things, and watch the environment. I see someone who's raising their hand.
Yes, we have Hadil.
Yes.
Let her know. Yes, Hadil.
Oh, sorry, I have another question. Can we use this carrying technique with children who have cesarean gait, or
Yes.
because the flexion, or we can we with the can we just provide stability while we have flexion of the knee? Is it suitable ولا no?
So the child with cesarean gait, which is the extension pattern where the knees are crossing above each other, you can use this if the child does not have a lot of, or if the child has a lot of control over their trunk. The one I use with a child with the spasticity and a lot of pattern or spasticity in the lower limb is the same as this one, except that the child would look towards me. Okay, so actually I use my hips. I put each knee on the side, one on my tummy and one on my back, and then I provide the child with support from the back. So it's almost like we switch the child towards the mother. Instead of his face away, his face is towards the mother. This helps a lot with the extension pattern in the lower extremity for a spastic child, because this is the way that I can actually break the pattern by doing abduction at the hips. Okay? Does that make sense, Hadil?
Yes, that makes sense. But I just have another question.
Yes.
That when we have a cesarean gait, sorry, children with cesarean gait have have hyperadduction with their legs. They are going into adduction, but
adduction and internal rotation.
Internal rotation, yes. Aren't their knees going into some flexion? That's what I'm asking about.
Yes, the flexion, the extension pattern. I think I mentioned this earlier. Let me go back to just show you the picture, because I think I mentioned it here. Yes, I said that in this, we call this the extension pattern because it's extension in the hips, it's adduction, it's internal rotation, but you can see that the knees can go into slight flexion. Okay, it's extension because the hips are in extension and the foot is in plantar flexion. Okay.
Get it. Thank you.
Okay, welcome. Okay. The last thing I want to tell you is how to lift the child. So we're talking about a small child, and this here is focused mainly on the parents. This is how we teach the parents the techniques that we as therapists use as well. How to lift something heavy, which in this case it's the child, without harming your back. I think this is essential for me. I always make sure that the parents learn this, because honestly, I've seen a lot of parents who come few years into the future of their child with a lot of back pain or even injuries at their vertebral column, which causes them to stop being able to help their child. We really need to teach the parents this. So how to lift the child, or how to lift anything heavy, so the wheelchair of the child or any equipment that the child is using, without harming your own body. So the first step is always go close. In this case, we're telling the parents, you're going to carry your child. So go very, very close to the child, to the bed of the child. The second thing, you need to fix the body of the child. So typically hold the child from their chest, so under the arms. Flip the child sideways so that you can help yourself and get a little bit of control. And then turn the child so that their upper trunk, their chest, is on your arm, and your other hand holds them from the pelvis, okay? And then you turn the child. So this is a very good way of holding a child who is small and from the bed. You see, what's important for me here, the mother did not bend her back a lot. So her back is always straight, which means that we are not causing harm to the back. Also, the way that she lifted the weight of the child is by flipping the child and getting the child to this point, which is the closest to her body, and then carrying the child weight. So she's not putting a lot of pressure on her trunk or in her vertebral column. Someone is asking to repeat the question, the steps. Yes. So first step, the parent needs to get really close to the bed, to the child. Second step, both arms under the arms of the baby. Third step, we turn the baby towards one arm, which is underneath the baby. Fourth step, the arm which is underneath the baby is carrying the baby from their chest, so controlling the upper trunk, and of course, this means that we are controlling the head. The other hand moves towards the pelvis, and we carry the child from the pelvis. Okay? And then the last one, just by holding the child, we bring them towards us so that their face is going towards the environment. The hands remain on where they are. The second one, for lifting a child who is heavier, so older child, we're lifting the child from the floor, okay? So first thing, again, the focus is on the parent here. The first thing we teach the parent is to go closer to the child, bend your knees, keep your back straight, take your child as close as you can to your body, okay? Place your arms where you want to put them. So depending on the way of carrying. So in this case, one hand is carrying the child from underneath their shoulder. The other is surrounding or carrying the pelvis. But just bring the child all the way towards you so that you're holding the child, and then stand up using your knees. So the back is straight. We did not bend the back. And this means that the back is preserved. The vertebral column is not at extreme pressure. And then you stand up, okay? Okay. I think that is the end of my lecture. I would like to say it's a workshop, but it's a little bit more like a lecture. I would like to see if anyone has any questions or anything that's not clear, or if you want to ask a question that I didn't mention.
It was a very clear and informative lecture. Thank you so much, Doctor.
Thank you.
And let me see the chat.
Yeah, I don't think anyone. I
Oh,
just
yes,
realized that I gone over the time by 15 minutes. So I'm sorry for that, but yeah.
No worries, no worries. They said thank you, Doctor.
Yes. Someone raised their hand, I think. Salma.
I believe Salma, yes. Let me check.
الله يعافيكم يا جماعة جميعا.
Yes, Salma.
مرحبا، يعطيك العافية دكتورة.
يعافيك يا رب.
هلا أنا سؤالي for someone with experience مع CP متى يعني بيكون إلي الحق إنه expectations تكون low مع cases يعني without being too pessimistic.
سؤالك it's very very smart actually. هلا سلمى, the more you see children with CP, the more you develop the skill of estimating functional improvement. Okay, بس
Okay.
the key point for me is that it's not only about the child, it's always about the parents. So
Yeah.
some children, they have very severe, very difficult situations, but the parents are really good at handling their child, are really good at following up at home, at providing the support that the child needs. So you see that the child is improving more than you expected. While at the same time, I've seen children, hemiplegic children, which means that they should be easily, easily given a lot of mobility and they can be dependent. And it's an easy, really, typically motorly, it's an easy situation, but because the parents are not cooperated, the parents are not really believing that their child can improve, that over the years you see the child reaches a plateau and they don't really improve. Okay, so I think when you estimate that, take into consideration a lot of other things, not just the situation of the child.
Okay, thank you so much. يعطيك العافية دكتورة.
يعافيك يا رب.
Thank you, Salma.
يعطيك العافية. أحكي كلمة. Hello.
I think عايشة. تفضلي.
Yes, عايشة.
هاي دكتورة نسرين. نورة حبيبتي يعطيك العافية. دكتورة نسرين كالعادة دائما مبدعة. Very comprehensive.
شكرا لك.
يعني هيك straight forward على الموضوع إنه كله we have always to think about facilitation for what we want and inhibition of the atypical position or form of movement. في شغلة حابة أذكرها تعلمتها أنا صراحة من زميلة فلبينية علمتني شيء تاول سبلنتينج. هلا أكيد في الأوضاع بالأوضاع الحالية أكيد السبلنتات هن أصلاً very expensive خصوصاً الثيرموبلاستكس. ففي تكنيك كنا نعمله عشان نحافظ على البوزيشن بعد ما نعمل الفاسيليتيشن، زي ما مثلاً ذكرتي إنه أنا ببدأ من الشولدر إذا بدي أعمل فاسيليتيشن opening the fingers، فببدأ من الشولدر بعدين على الإلبو بعدين بعمل سوبينيشن عشان أحافظ. هذا أنا بس بجيب مثال يعني it can also be used. عشان أحافظ على هذا البوزيشن ممكن أستخدم تاول بتنيه بطريقة بحيث يكون لي الإلبو جوينت أوكي up and down، وبلفه بعمله راب حوالين المفصل. إن شاء الله أكون واضحة بالشرح، أنا مش قادرة أفتح الكاميرا أوكي. وبعدين أحاول إذا في عندي كريب باندج أو إذا باندج يكون شوي إلاستيك أوكي، وبلفه حوالين التاول سبلنت عشان أحافظ على البوزيشن قدر الإمكان. مثلا في حالة بدي أعمل مثلا ويت بيرنج للإيد اللي أنا حطيت عليها السبلنت، حسيت أنا هذا الإشي لما كنت بشتغل مع الأهالي إنه كتير بخدم، إنه في حالة ما السبلنتات متوفرين وبيحافظ على الفاسيليتيشن اللي عملته والإلنجيشن تبع الناس لأطول فترة ممكنة.
واسهل للاهل. هلا وانا كنت عم بحضر بالمحاضره صدقا كنت عم بحاول قد ما اقدر اتجنب استخدام ادوات، بس هو فعليا لما كنت انا اشتغل مع اطفال سي بي كنت دائما اعطيهم او اطلب منهم يشتروا الجيترز مثلا، واللي هي زي السبلنت القماش، اللي هي بعد ما يحطوا الوضعيه اللي بدهم اياها بالارم وحتى بالليجز دغري بيلفوا حوالين الالبو او حوالين النيز الجيترز، لانه بعدين بيقدروا يحطوا الولد بويت بيرنج بيسهل عليهم كتير. فيس هو تيبيكلي لازم نستعمل اشياء زي هيك. مثلا تيبيكلي لازم استعمل بعد ما اضبط وضعيه الراس اني احط الولد بكرسي ويكون الكرسي عامل له سبورت عشان ابلش اطعميه. فيس في سكشن كبير والله، يعني بتفيدينا مس عايشه اذا انه انت بتعملي لنا إشي زي هيك مثلا تكماله للي انا حكيته، اللي هو how to use household materials
هو
لل positioning.
يعني لأنه أنا عم بفكر إشي موجود بالبيت، يعني الجيترز بدهم شرية، بس أنا عم بفكر إنه التاول مثلا إشي موجود، البشكير.
تاولز يس. يعني ممكن احنا نحكي انا وياك نفكر بإشي كيف نستعمل الهاوس هولد ماتيريالز مثلا، اشياء كومبوننتس ممكن اي حدا يلاقيها، قماش الى اخره. يس لانه بيكون كتير مساعد بصراحة.
كثير حلو، بس هلا لانه الدنيا شتاء يمكن يكون صعب انه نطبقه، بس قدام شويه ممكن اللي هو البيبر بيزد تكنولوجي. انا بتذكر في الزمانات
very
آه،
interesting.
واحده بريطانيه انه كيف نقدر نعمل الكورنر سيت يا من الكرتون المقوى، وبنعمل بطريقه زي كانه بالاخر بتحول لشيء زي كانه خشب. حتى ستاند
برافو.
عملناه من اسمه بيبر بيز
لا
تكنولوجي.
انا بعرف انهم الكرتون بيجيبوه بتذكر كمان ببريطانيا اكشلي عملوه. بيجيبوه بيحطوه مع مي وبيعجنوه كتير ومعه جلو بيحطوه لحد ما يصير زي العجينة، وبعدين بيستخدموها تو كونستراكت، بس كانوا يعملوا اشكال منها.
at the end بصفي كأنه عاملين مصنعين إشي من الخشب، كأنه يعني هو
صح بتذكر انه كان يعني حتى عملوا دول منه، بس لا ما خطر ببالي، بس والله very good idea. يعني let's do that، لانه انا فعلا تغلبت وانا عم بجهز هاي المحاضرة انه السكشن تبع السيتنج، السكشن تبع الويل شير، السكشن تبع السبلنتنج، لانه هدول essential to be honest with you. بس هذا ما قدرت الاقي طريقة اني انا اجيبه مع مراعاة انه الواحد ما عنده ادوات يعني.
بس هلا ممكن نعمل ورك شوب لقدام خصوصا للناس زي انهم يستفيدوا من الكرتون هذا، يصنعوا منه اشياء للسيتنج للستاندينج للبوزيشننج بشكل عام. بس يعني بلكي لقدام شوي
ان
بنعمل
شاء الله ان شاء الله. هذا بالمستقبل ان شاء الله.
إن
شكرا
شاء
كثير
الله
والله،
بإذن
فكرة
الله.
كثير حلوة.
شكرا.
عافية. يعطيك
طيب
الف
يا جماعة أنا بدي أقول لكم شكرا للحضور. أنا بعرف إنه نورة بدك تقولي شكرا ورح أترك لك تختمي معنا، بس أنا حابة كثير أشكر كل اللي إجوا. يعني يا ريت بإيدي إنه أنا أشوفكم كلياتكم وأقول لكم شكرا إنكم حضرتوا. بتمنى إنها تكون مفيدة للفئة اللي أنا يعني شخصيا بتمنى إنهم يستفيدوا منها، أهلنا بالضفة وبغزة، وإنه عن جد أتليست يستفيدوا شوية أشياء. بتمنى إنه إحنا نضلنا مشغلين، انه احنا نلاقي لهم تدريبات باكثر من مجال، وانا جاهزه. يعني ان شاء الله بنضلنا على طول انه نجهز اشياء سواء لزملائنا بالاردن وباي بلد، بالكويت وبكل الدول، بس كمان سبيسيفيكلي لزملائنا بفلسطين. وبشكركم مس عايشه ونوره على جهودكم مره ثانيه، وانا انبسطت كثير. وبتمنى يا رب إني ما أكون قصرت، يعني يكون كل إشي واضح للكل. وحبعت مع مس نورة الكتاب والماتيريال كلياتها، وإن شاء الله بتنزلكم إياهم كلياتها، وبالتوفيق للجميع إن شاء الله.
إن شاء الله. Thank you so much, Dr. Nisrin. It was a very informative lecture and we really enjoy it. Thank you so much and hope it reach for the point and for our mission to reach in Gaza people this information. So thank you so much.
نورة.
Hope to see you everyone next lecture, inshallah.
إن شاء الله.